This essay provides physical therapists with a structured playbook for assessing and treating common orthopedic shoulder conditions. Our primary focus is on clinical clarity. This means using a systematic approach that is easy to follow. It means prioritizing clear steps in our examination. It means selecting common, validated tests. It means establishing clear treatment priorities based on our findings. The ultimate goal is to enhance your clinical reasoning. This framework will help you make confident and effective decisions in a busy clinical environment, leading to better patient outcomes. We will keep the language simple and direct to ensure these concepts are accessible for clinicians at all stages of their careers, new graduates and seasoned practitioners. The scope is centered on non-operative orthopedic shoulder pathology. The shoulder is often described as a complex joint, and for good reason. It is not a single joint but a sophisticated anatomical region comprising 4 key articulations: the glenohumeral joint, the acromioclavicular joint, the sternoclavicular joint, and the scapulothoracic articulation. The glenohumeral joint provides the greatest range of motion of any joint in the body, but that mobility comes with inherent instability. The shallow glenoid covers about 1/3 of the humeral head, making the joint reliant on other stabilizers. Static stabilizers include the joint capsule, the glenohumeral ligaments, and the glenoid labrum. Dynamic stability is provided by muscles crossing the joint, most notably the rotator cuff, supraspinatus, infraspinatus, teres minor, and subscapularis. Together, they compress the humeral head into the glenoid, concavity compression that maintains congruency. Weakness, fatigue, or tendinopathy disrupt this balance and can lead to pain or injury. The scapula's motion is pivotal. Scapulohumeral rhythm enables full elevation and optimally positions the glenoid. Muscles including the serratus anterior, trapezius fibers and rhomboids coordinate this motion. Scapular dyskinesis is common and can both contribute to and result from shoulder pathology. Thoracic mobility deficits or serratus weakness can reduce subacromial space, affecting rotator cuff mechanics. A successful treatment plan begins with a meticulous and systematic clinical assessment. The history is paramount. Clarify location, nature, and intensity of pain, identify aggravating movements and what provides relief, determine onset and mechanism, sudden trauma or gradual development. Ask about night pain, which can indicate rotator cuff or other inflammatory conditions. Establish work, sport, and recreational demands. Undress to visualize the girdle, neck, and upper back. Observe posture from all sides. Note asymmetry, clavicle alignment, scapular positioning, swelling, bruising, and muscle wasting, especially in the supra and infraspinatus fossae. A protective, guarded posture hints at severity and irritability. Begin with active range, assess movement quality, willingness to move, and painful ranges. Pain between 60 and 120 degrees during abduction often suggests subacromial pain. Compare passive to active RM. Greater passive suggests weakness or possible tendon rupture. Equal restriction suggests capsular tightness. Test rotator cuff isometrics and key scapular stabilizers. Use clusters to increase diagnostic accuracy for subacromial pain, Hawkins-Kennedy, near, and the painful arc sign. For instability, perform the apprehension test and the relocation test. Always screen for red flags, fracture after severe trauma, signs of infection, progressive weakness or sensory loss, and refer immediately if present. Rotator cuff tendinopathy is among the most common presentations. Typical features: lateral shoulder pain, worse with overhead activities or reaching behind the back. Expect a painful arc, pain and weakness with resisted external rotation and abduction, and positive impingement signs. Active motion is painful and limited, yet passive ROM is usually maintained, distinguishing it from frozen shoulder. Pain often follows excessive or unaccustomed tendon load. Subacromial pain syndrome involves structures in the subacromial space, the rotator cuff tendons and subacromial bursa, with pain commonly in the 60-120 degrees arc. Hawkins-Kennedy and near tests compress these structures to reproduce symptoms. View this as a symptom cluster tied to cuff function and scapular control, not just a pinched structure. Frozen shoulder presents with global loss of active and passive ROM, especially external rotation. The course progresses from a painful freezing phase to a stiff frozen phase, then a thawing phase with gradual motion return. Expect a firm capsular end feel and near equal loss of active and passive motion. Instability, common in younger athletes, involves a giving way feeling, recurrent subluxations or dislocations. A positive apprehension test reproduces the patient's sense of instability, not just pain. AC joint injury presents with point tenderness at the top of the shoulder and pain on crossbody adduction. Glenohumeral osteoarthritis typically causes deep joint pain, stiffness, and crepitus in older individuals. Synthesize findings into a clear clinical impression to guide targeted management. A successful program rests on core principles, starting with pain and inflammation control, especially in the acute phase. Educate on activity modification and relative rest. Avoid aggravating loads without full immobilization. Optimize sleeping positions. Ice or heat can provide short-term relief, but focus on self-management. For capsular tightness, gentle passive stretching, pendulum exercises, and graded joint mobilizations. Use pain-free active-assisted ROM progressing to active ROM, respect irritability, pushing pain can set progress back. Aim for gradual restoration of normal arthrokinematics, then establish scapular control and neuromuscular timing. Target serratus anterior and trapezius fibers with simple, clear cues. Start with retraction and depression, then functional patterns. Begin with pain-free isometrics. Progress to isotonic concentric and eccentric loading. Eccentrics benefit tendinopathy. Strengthen the rotator cuff, parascapulars, and larger shoulder girdle. Then tailor to task-specific, real-world movement. A 45-year-old office worker presents with 3 months of gradual right lateral shoulder pain, aggravated overhead and at night, suggesting rotator cuff involvement. Findings: forward shoulder posture, painful arc, full but painful end-range passive ROM, weakness and pain with resisted ER and abduction, and positive Hawkins and near. Impression: rotator cuff tendinopathy with scapular dyskinesis. Plan: education and pain control, pillow support, gentle pendulums, simple desk scapular drills, and pain-free isometrics, then reassess at 3 weeks. Track progress with ROM, strength, and quick dash. Advance to slow, controlled isotonic loading and serratus strengthening. In summary, use a structured assessment, apply phase treatment principles, and consistently track outcomes to deliver efficient, high-quality care and safe return to activity.